We present our standard technique for the Pectopexy, which is a very good treatment for the urogenital prolaps. The first step of the procedure is to cut the right round ligament that allows us to identify the retroperitoneal element, and we have to follow the medial aspect of the external iliac vein till we reach the pectineal ligament. We do the same steps on the left side, sealing and cutting the left round ligament, opening the retroperitoneal space, identifying the external iliac artery and vein, and we open the space just below the external iliac vein, which is the pectineal ligament, and this place will be used for anchoring our mesh later. The next step of the procedure is to do the vesicovaginal dissection. For that, we have to use the uterine manipulator, and the uterus is pulled toward the sacrum. That allows us to put in tension the vesicovaginal peritoneum. The assistant pull up the bladder, and we have just to follow the bubble for cutting the peritoneum from one round ligament to the other. Now let's develop the vesicovaginal dissection. This maneuver is crucial for a good anatomical and functional outcome. And it's really important for the prolapse surgery to do a deep, large and wide vesicovaginal dissection. Our goal is to reach the trigone area, because more you are deep, more you are lateral, better your functional outcome will be good, particularly in case of stress incontinence urinary. Sometimes there is a dense adhesion in the middle aspect of the vagina. It's mandatory to seal and cut this adhesion and to arrive to the trigone area. In my opinion, 10 centimeter dissection is a minimum for a good anatomical and functional outcome. As you see, in this case, we are more than the trigone area, and we can touch the retropubic space. This patient has a stress incontinence urinary, and after the procedure, this problem was completely resolved. We put now a sponge for hemostatic reasons, and we can begin the supracervical hysterectomy. It's a postmenopausal patient. For that, we have the use to do a subtotal hysterectomy with bilateral adnexectomy. It's important as well to skeletonize both the uterine pedicles, so you have to remove the peritoneum surrounding these pedicles. That allows us to seal the left uterine artery. We do the same step on the right side, cutting the right round, the IP ligament, sealing and cutting both uterine arteries, on the right firstly, on the left now, and we will do a subtotal hysterectomy. For that, we use a monopolar needle that was placed in the left iliac operative trocar, and as you see, the supracervical hysterectomy is quite fast. Let's now obliterate and completely close the remnant cervix for two reasons. The first one is to decrease the risk of ascending bacterial contamination from the vagina, and the second step is to do a cervicopexy that allows us to open the posterior rectovaginal compartment, and even there is no rectal cell, we have the use to put a posterior mesh. For that, we have to open from one uterosacral ligament to the other, and we continue our dissection till we arrive to the anal canal. If you follow the bubble, this dissection is quite bloodless, and we don't do the same dissection that we have used to do in a sacrocolpopexy. We don't discover both puborectal isthmus. We stop, as you see, just in the level of the anal canal. We use for that 5mm sealing device, a ligature, that allows us to win time in this long procedure. Now we put our crush-shaped mesh and we will fix the mesh with Vicryl 5mm absorbable tackers, firstly on the cervix and in the second time in the posterior compartment with the same tackers. As you see, it's really important for the mesh to be completely plastered on the posterior vaginal aspect. Let's remove now the sponge and we do the same. We apply the mesh on the entire vaginal aspect till we reach the trigon area, until we reach here the posterior aspect of the pubis. Let's cut now the mesh excess, and you can see how the mesh is well plastered on the vagina. The next step is to connect the anterior and posterior mesh with the non-absorbable stitch. The needle is passed through the remnant cervix, and with this technique there is absolutely no risk for mesh erosion. We fix the mesh on both sides of the remnant cervix. The stitch that we use, it's a non-absorbable multifilament 81 stitch, number 1, and as you see, we can use all the suturing technique, intracorporeal, extracorporeal, it doesn't matter which is matter, but the mesh must be completely plastered on the cervix. Now we will use the same stitch, 81, and we will pass 2 times through the pectineal ligament, which is a stronger ligament than the anterior vertebral ligament, which is used for the sacrocolpopexy. And we pass the stitch 3 times on the lateral arm of our cross-shaped mesh, and we will close by extracorporeal knotting technique. In my opinion, it's really important to plaster completely the mesh on the pectineal ligament, and it's mandatory to avoid dead space between the mesh and between the ligament. We cut the mesh excess and we do the same step on the left side. We pass the needle through the pectineal ligament the first time and the second time for a better security. And we will pass the needle 3 times through the left lateral mesh arm, and we will fix the mesh by extracorporeal knotting technique with the knot pusher, as you see. And as I say, it's really important to plaster the mesh and to fight against the dead space. Let's cut the mesh excess, and let's do, in my opinion, the most important step of this Pectopexy, and we will shrink the mesh with the Etibon 1, and we pass the stitch through the entire cervical length, and this step is crucial for a good prolaps treatment, because with this stitch we can align both lateral arms and we can correct the prolapse as desired. It's important to align both arms, and there will be 30% retraction after the surgery and after 3 months. You can see how the mesh is well plastered anteriorly and posteriorly. And let's now do a peritonization to decrease the risk of postoperative bowel adhesion and bowel occlusion. We use for that a running suture with monofilament 1, it's a monocrete one. We use the bladder peritoneum that will be connected with the rectovaginal peritoneum. As you see, with this running suture, the peritonization will be good. Now we finish our running suture at the level that we have began the suturing, and you can see the closer by extracorporeal knotting technique. So this is our technique for doing Pectopexy. We have just to morcellate the uterus. I hope this video was interesting for my colleague, and see you for my next video, and thank you for your great attention. Goodbye.